With us today is Dr. Murray Epstein from the University of Miami Miller School of Medicine. Dr. Epstein has clinical and research interest in RAS, MRAs, and hyperkalemia. Welcome, Dr. Epstein.
Glad to be here with you.
RAS inhibitors have demonstrated established benefits in the treatment of cardiovascular disease and for retarding progression of renal disease. However, these drugs increase the risk of hyperkalemia in both chronic heart failure and chronic kidney disease patients. Can you discuss how RAS-induced hyperkalemia has changed the clinical landscape for implementation of RAS inhibitor therapy?
Absolutely. I think that's probably one of the major upfront issues that we have as we manage patients with congestive heart failure and patients with chronic kidney disease. In terms of background, relatively recent reports have highlighted several important aspects of RAS treatment regimens that I believe have not been universally appreciated. First, the rates of hyperkalemia documented in the clinical trials, for example, the RAL study, Emphasis HF, they frankly don't reflect the prevalence of this complication in the real-world scenario. And we have examples of that. Reports by Shaw and co-workers and Boskert and co-workers have reported that the rates of hyperkalemia seen in the real-world setting substantively exceed the rates reported in the original clinical trials. For example, 2 and 2.5% in the randomized clinical trials versus 6 and 11% in a clinical treatment setting. So this is an important issue. We have a sense of false safety. We don't quite anticipate or appreciate the magnitude of hyperkalemia that can supervene. There's another important issue that I think deserves emphasis. As CKD progresses, the prevalence of heart failure and diabetes increases. So essentially, the increase in comorbidities enhances the risk of hyperkalemia, and based on the interplay of these comorbidities and the requirement for concomitant treatments, we have an increased susceptibility, an increased propensity for developing hyperkalemia.
As a follow-up on these comments, can you discuss the recent data highlighting the large gap between the recommendations in the evidence-based guidelines and real-world practice in the use of RAS therapies?
Yes, indeed. There are several recent observational and retrospective studies that speak to this point. As an example, in the retrospective analysis of data from the American Heart Association's Get With the Guidelines Coronary Artery Disease database, it was reported that less than 10% of eligible heart failure patients hospitalized for myocardial infarction were prescribed an MRA or an aldosterone antagonist at the time of discharge. That gap is truly striking. Additional data derived from the ESC heart failure database, the European Society of Cardiology, the long-term registry, a prospective observational study conducted in over 200 cardiology centers in Europe and the Mediterranean countries by the members of the European Society of Cardiology from a relatively recent period, 2011 to 2013, and including a total of enrollment of 12,440 patients. What they demonstrated is that 40% of patients with acute heart failure and 59% of patients had chronic heart failure, whereas 67 to 90% of hospitalized heart failure patients were prescribed the recommended RAS therapy, intriguingly, or shockingly, I should say, less than 30% were up-titrated to the recommended target dose. So these two studies really underscore a point. Number one, that patients may not be treated at time of discharge, and secondly, even if they are, they're not up-titrated as recommended by the evidence-based guidelines. To flesh this out, if you will, I and colleagues conducted a recent analysis which I think just highlights and confirms this major gap. We undertook what's called the big data analytics approach. It was a comprehensive analysis of a very large database of electronic medical records, Umedica database, and we started out with over 7 million de-identified charts, and we try to evaluate 3 pivotal questions that are relevant to what we're discussing presently. Number one, whether RAS inhibitors are being prescribed according to treatment guidelines. Secondly, what happens to RAS prescriptions after hyperkalemic events occur? That is, what is the response of the health provider or the clinician caring for that patient? And thirdly, what are the clinical outcomes in the patients where the RAS inhibitors were either discontinued or down-titrated in response to the occurrence of hyperkalemia? And the results are disturbing, to say the least. And the insights and lessons that we can derive from this big data analytics study, I think, are important regarding the relatively pivotal role of RAS-induced hyperkalemia in disrupting or preventing appropriate implementation and utilization of guideline-mandated RAS treatment. Overall, the results of our study, which were published just 5 months ago, they clearly indicate that there is a substantial gap between the recommendations and the treatment guidelines and the real-world prescribing patterns for RAS inhibitors. That's exactly what we saw in the earlier studies that I discussed a few minutes ago. The other point is that we pay a price. The other point that we wanted to focus on is if indeed you were down-titrated or discontinued because of the occurrence supervening of hyperkalemia, did it matter? Because essentially that's the bottom line. And very simply, when we looked at mortality and other comorbid events, clearly mortality was greater and there were more events occurring in patients who either were discontinued and to a lesser extent, but still very significantly, were down-titrated. So the take-home message, I think, is very clear. If we can somehow avoid or cope with the hyperkalemia that occurs, we will enhance outcomes, which is really what the whole scenario is all about. And it's been called, there's a term that I've seen that I really like. This has been called the RAS paradox, the notion that the patients who stand to derive the greatest benefit with implementation of RAS inhibitors and MRAs are precisely the patients who are most likely to develop RAS-induced hyperkalemia. It's a catch-22, I think, is the clearest way to look at this paradox. So I think all of that speaks to the notion that if we had newer therapies that could deal with, that can cope with the RAS-induced hyperkalemia, there would be major benefits that accrue over a whole range of initiatives.
Now, one of the areas of interest with any newly available drug is safety. I understand that there may be potential concerns regarding the sodium load presented by several of the potassium binders, including SPS. Can you elaborate on these issues?
Well, you've just touched on a very important area of current investigative and clinical concern with respect to the current availability of both currently available and imminent potassium-binding treatments for hyperkalemia. And that area focuses on what we term the counter-exchange ion. For the binders such as polystyrene sulfonate, which have been with us now for 50 or indeed 55 years, the one that is available in the United States, the counter-exchange ion, is sodium. And indeed, from one of the other binders that's being developed currently, ZS9, again, the counter-exchange ion is sodium. In contrast, the third binder, which was approved in October 2015 and currently available, Patermer, the counter-exchange ion is calcium. And what's important is that these differences are not merely biochemical oddities, but I believe they have important clinical implications with respect to how well these binders do and what the possible adverse events or side effects might be. If we look at the sodium cation component of sodium zirconium cyclosilicate, there's data which is not consistent, but I think bears interest. As I noted earlier, the counter-exchange ion is sodium, and there's some level of concern as to whether or not and to what extent sodium may be absorbed. That is, when the drug is taken, sodium is exchanged for potassium, and what is the fate of the sodium? To what extent is that absorbed? In sodium-retentive states, including heart failure and chronic kidney disease, absorption of sodium, obviously, I think everyone can appreciate that readily, can promote hypervolemia and precipitate or exacerbate edema. This is clearly a problem with the long standby that we've had, sodium polystyrene, and also with sodium zirconium cyclosilicate. And indeed, there are warnings and caveats that have been applied, warning about this possibility in the setting, for example, of congestive heart failure. Now, first of all, let's look at it scientifically and appreciate what the actual content of sodium might be in some of these binders. In sodium zirconium cyclosilicate, it's substantial. The drug is reported to contain approximately 8% sodium by total weight. Therefore, the approximate sodium content of, for example, a 10-gram dose of sodium zirconium silicate equates to approximately 800 milligrams or 35 milliequivalents of sodium. So that's a substantial dose. And the question is it in part absorbed to an important extent or not? And the data are conflicting, frankly. We don't know. On the one hand, data was presented at the American Society of Nephrology meeting last November in San Diego, looking at a large database of patients who completed at least 3 months of therapy with this agent, and were told that the rate of peripheral edema was relatively low, 7.7% or essentially 30 of 685 patients, 7.7%, and of these, roughly 4% required treatment with diuretics to mobilize that edema, that excess volume that occurred. Of interest, and again, this hampers me in interpreting the data, the investigators in that report at ASN reported no significant change from baseline in either weight or blood pressure at any point of the study. So one would like to have seen either decreases or increases that would correlate with the extent of the edema. Interestingly, in a recent report by Stefan Anker in Europe on in patients with heart failure presented in the European Heart Journal, Congestive Heart Failure, they noted that with zirconium cyclosilicate, that patients randomized to the drug or placebo had significant differences. In their report, in their publication, roughly a 10 to 11% occurrence of edema was seen with a 5 or 10 gram dose. And indeed, although the numbers are small, but in the table in that report, as many as 20% of patients had manifested edema with the 15 gram dose. So I think one of the issues that we should look at, too early to really make firm conclusions, but as we look at it prospectively, we should ask the question in larger trials, and especially in the clinical setting, how frequently might the sodium counter-ion exchanger be absorbed, and to what extent might it promote edema and volume retention in patients who are sodium retentive, that is congestive heart failure, or patients with chronic kidney disease. So going forward, this will be one of the key areas to keep in perspective and to look for additional data.
Dr. Epstein, can you provide us with some concluding thoughts?
Yeah, I think probably the major comment that I would make is the following. Clearly, we need to be able to not only implement treatment with RAS inhibitors, but also to sustain this long term. And what I've called evidence and data in my discussion today to make the point that frequently in patients who have heart failure, chronic kidney disease, or the comorbidities, the very treatment which is life-saving and confers major clinical benefit, the RAS inhibitors, in and of itself, precipitates or provokes hyperkalemia. So I think the next step in being able to enhance implementation is to develop our armamentarium with respect to drugs that can control this hyperkalemia, the binders, and in turn can afford us the ability to have sustained normokalemia even in the setting of drugs such as RAS inhibitors who might exacerbate the setting. I'm optimistic in terms of how the clinical landscape will change favorably with the availability of these drugs.
Thank you for your time today, Dr. Epstein.
My pleasure.